I would like to welcome you to this panel with the name Health Literacy and Chronic Disease. I am Christine Borge and will be the moderator of the panel. I am an associate professor at Lovisenberg Diakonal University College and also Department of Interdisciplinary Health Science at the University of Oslo, and I'm also a senior researcher at Lovisenberg Diakonal Hospital in Norway. During this panel, you will learn about rheumatic diseases, diabetes, heart, and parents of children with gastro diseases and CPD. We have had some changes to the program due to sickness, so I'm sorry that you will not hear about kidney disease. During the session, you will be able to ask questions via the question and answer button. You are also welcome to use the comment using chat, and you will also be able to raise hands at the end of each presentation. So the first presenter today is Mark Bakker. He is a lecturer and researcher at the Maastricht University in the Netherlands. He will have a presentation about addressing health literacy needs in rheumatology care. What do we know so far? So welcome, Mark.
Thank you, Christine. I'm just going to share my slides. There we go. And that should be it. Good morning, afternoon, or evening, everyone watching this panel today. I'm very excited to get to talk about this topic in the next 12, 13 minutes. And I'll be tapping into the experiences from my PhD research, which I finalized last year, but also other lessons learned from rheumatology across the world. So it's always difficult to summarize at least 4 years of research in a presentation of 13 minutes, but what I want to focus on is what do health literacy challenges in RMDs, rheumatic and musculoskeletal diseases, RMDs, look like, steps towards action for RMDs using health literacy measurement, and I'll finalize with some words of warning, things we've learned about addressing health literacy needs that we should take into consideration. If you're just coming out of the plenary session and you need to use a bathroom break and need to skip part of my presentation, feel free to do so, but make sure that you stay for these takeaway messages. At least consider diversity in health literacy needs to improve impact of services and intervention. And I'm stressing that diversity. There's no one type of health literacy need. Different patients have different needs, and we should cater to that. Impactful health literacy actions are rooted in the local context and generated through local wisdom. So the local ideas are the best ideas to move health literacy thinking forward. And I want to emphasize that the work in this field is ongoing. So I'm going to mention some, ongoing lessons, but feel free to connect for more. Not just our team, but other teams across the world are working on these challenges in rheumatology care. A little bit of context about the care for people with RMDs in the Netherlands. We did our research in 3 different centers in the Netherlands, but we have access to healthcare across the country. RMDs affect over 2 million people in our country, in a country of about 18 million people. A large proportion of that is osteoarthritis and osteoporosis, but about 1.5% of our population has a chronic inflammatory rheumatic disease, which are the most, or among the most impactful conditions, primarily treated with outpatient care. So you see your healthcare provider 2 to 4 times a year for about 15 minutes, primarily through rheumatologists, but also supported by nurses, nurse practitioners, physician assistants, and other healthcare professionals. And we've seen an increased use of digital health and telemonitoring within the way that we deliver care. And there's an increased attention for shared decision making and an active role for patients, which is very positive in a lot of ways, but also challenging for patients. Because what kinds of challenges do we see when it comes to health literacy? So our research and research of our colleagues in the Netherlands showed that according to healthcare professionals, challenges in healthcare delivery are related to patients' difficulty in navigating the system, difficulty in following advice, describing what kind of complaints people have, like what is the real issue that people want to see addressed in their consultation. The interaction between healthcare provider and patient, very difficult to point exactly at what that issue is, but healthcare professionals feel like something in their interaction isn't going well. And therefore, the patient may not have walked away with the main insights needed to be happening in that consultation. Participation in shared decision making is a challenge. Non-adherence or no-shows to appointments are a challenge. And cultural and language barriers, I purposefully put those at the bottom. They're always relevant. Language is a huge underlying factor when it comes to health literacy needs, but it's much more than just language. Healthcare professionals also recognize that they find it difficult to recognize those challenges in practice at the point of care. And we saw that in our work as well. I'm not going to have you interpret this full figure. There's a video abstract that you can access through YouTube about this study that we did. But we looked at the 9 domains of the health literacy questionnaire, and you see them on the left. And we checked on a 10-point scale if there was a difference of more than 2 points between the score that the patient had and the score that the healthcare professional filled out for those patients. We thought that that's a relevant discrepancy. And we see the green is in the middle is good, but the red on both sides is an over or an underscoring by healthcare professionals. And most problematic is that healthcare professionals think our patients are much stronger at critically appraising information than they actually are in about 1/3 of patients. Also quite pressing is the fact that in almost 1/5 of all patients, healthcare providers don't really know if there's social support for health among patients. That could mean that they don't know if someone has any social support for their health, or it could mean that they know about the social support that's there, but they don't know to what extent that's supportive to the healthcare needs of individuals. Patients report similar challenges, but worded differently. So it's about finding the right care, getting a diagnosis, feeling unheard by providers, and just the general challenges that we know about healthcare appointments, that the medical appointments fly by. It's difficult to retain information over time, and particularly relevant for rheumatic diseases, it's very difficult to oversee the long-term impact of a condition. I'm taking medication in the now, but what will that do and how will that affect me in the future? Also, changes in medication or changing in health status are quite common among patients with rheumatic conditions. It's difficult to get to the right dosage of medication, and these changes are challenging to deal with. And this leads to negative intermediate outcomes. But for example, medication adherence, it's a classic when it comes to health literacy challenges. But we also saw that it's not just medication adherence, but also access to medication, or maybe we should see that as prescription behavior of our healthcare providers. So in the group of people with good health literacy, we saw that they had better access to what we call biological DMARDs, disease-modifying anti-rheumatic drugs, which are the most complex, expensive, but also most powerful drugs that we have against rheumatic conditions. And this is among patients with rheumatoid arthritis specifically. And we saw that people with several health literacy limitations, so limitations across domains of health literacy, they were much more likely to be prescribed prednisolone, which is usually our short-term emergency stop to disease activity or rising disease activity. But people were prescribed that over the long term, which comes with adverse effects that we ideally would like to avoid. So we see that despite our best intentions, we provide care in a different way to different people based on health literacy, which in turn impacts outcomes. So we see higher disease activity in people with more health literacy limitations, and other studies have pointed this out as well: lower functional status, worse overall health, more comorbidities. And we see that's not just in adults, but also in young people, particularly young people that have a rheumatic condition that transition into adult care. One of our colleagues looked at that transition process is challenging. Issues with adherence, and particularly the social aspects of illness aren't always discussed enough when moving from youth care to adult care. Oh, that was not the button I was supposed to press. Here we are. So what can we do? We can improve health literacy, but we try to focus on what can we do in our health systems and services to be responsive to the health literacy needs of people and to make services available and accessible. I am going to quickly mention the universal precautions approach, the one-size-fits-all approach developed in the US that can help organizations get started on a number of activities to improve health literacy responsiveness, because there is a rheumatology-specific toolkit available, and it's just a great starting point for organizations to work with. But we also sometimes need a slightly more tailored approach, not just one size fits all, but we want to focus on that health literacy diversity that we see in our populations. And we, in our case, use the Ophelia process for that, Professor Osborne explains in much more detail earlier in the keynote, so I won't go into that much now. What that looks like, a needs-based approach to us, is combining quantitative assessment, for example, using the health literacy questionnaire, data from patients, real-life data, with qualitative co-design consultations with the experts in the local context, health professionals, and patients. And what we saw in our context was that we had diverse health literacy strengths and weaknesses among people with different rheumatic musculoskeletal diseases. And the beauty of these cluster analysis that you can do using the HLQ is that you have an overview. You see within the box a profile of people or for a group of patients with particular strengths and weaknesses across the board. And that can be combined with individual healthcare information to create these patient cases that really bring patients' challenges to life. For example, this case about Mrs. X, who has particular challenges with critically appraising information, but she scores quite high in the support by her social surroundings as well as her healthcare providers. So there's strengths that we can tap into to compensate for those weaknesses or difficulties. And we ask the questions, is this recognizable? What are the challenges this patient faces in your healthcare facility? And what can we do differently? In our case, what did that yield us? Over 150 ideas to improve care in the local context, and some of them have already been implemented and others we're still working with. But to give you an idea, this is about improving the professional patient interactions, making sure that we have training programs in place for both patients and health professionals, and working on the organizational sides. Making changes to the way that we deliver care, make appointments, etc. Making changes in the way we involve other healthcare professionals or non-healthcare professionals in catering to the needs of people, and having materials available that people need to be able to manage their own care. What's next for us is training healthcare staff in health literacy responsiveness. This is an ongoing process. Health literacy is gaining traction within our field, and we notice the increased attention, but there's a lot of work left to be done about that, and we'll be using the chat, the conversational health literacy assessment tool for that, in an adapted form for inflammatory rheumatic diseases, and this is, again, ongoing work. We're hoping to achieve health literacy responsive care through our project. And I want to emphasize that there's ongoing work in different contexts. It's not just the team in the Netherlands working on these challenges, but all over Europe, groups are working on this. And just as a quick reminder of what the health literacy assessment tool looks like, it is a conversation tool with different questions that helps healthcare providers find health literacy challenges at the point of care, because we know that estimations are difficult. So we need them to be able to ask the right questions to really surface, okay, what can we do in this moment to help this particular patient? Now, I'm going to end with some words of warning of the things that we've learned. One is that writing in plain language is not easy and not enough. Writing plain language is really important when it comes to health literacy and health literacy responsiveness. But what we saw with organizations that really tried to have accessible and understandable information available, this is during the first wave of COVID-19, we saw that despite those best intentions, the texts were still too complicated, still too many difficult words. And then even if the texts make it to a accessible language level, that doesn't mean that people know how to apply that information to their particular situation. So we need to do more than writing plain language only. I've already said that estimating patients' health literacy is very difficult, so we need measurement and we need dialogue. We can't just base our assumptions and go by them only. We know that patient representatives may have different health literacy needs than the target population. This is a study we did among patient representatives. You see their scores at the very bottom. And if we compare that to a health literacy profile of patients with rheumatological conditions in our practice, we can sort of estimate them at the middle. But if we dive further, we see that our patient representatives score higher on actively managing health and score higher on critical appraisal of information, and quite significantly higher too. At the same time, our patients scored higher on navigating the health system and having healthcare provider support. So all is there to say is, you see the cluster analysis of these patients. We see that the most red scores, the most challenging profiles, didn't really exist for those patient representatives, but at the same time, health literacy challenges are there. So there's relevant challenges that are available that we should be aware of, but the people that we engage with sometimes for our projects, the people that we engage as research partners, they might actually give us advice about different health literacy challenges than what the patients that we serve in our daily practice are experiencing. More interventions isn't always better. A study that we found in osteoporosis patients, or our colleagues here did in osteoporosis patients, found that a multi-component adherence intervention, which consisted of a decision aid and follow-up with motivational interviewing, actually reduced adherence in people with limited health literacy, more so than usual care, and especially compared to people with higher health literacy scores. And this was measured using the health literacy survey, the European Health Literacy Survey. So actually this intervention seemed to have the adverse effect where it was too complicated to have people go through this decision aid and motivational interviewing, and actually reduced adherence in that subpopulation of people with health literacy needs. So it's really important that we're careful with this. Also, digital solutions are not for everyone. EULAR is the European Organization for Rheumatology Associations. They do points to consider, and for remote care, their note was that actually people have different health literacy and digital literacy skills. So thus, digital solutions aren't for everyone. And so we have to be careful with that. We need to have diverse options and solutions for diverse patients in our population. And that brings me back to where I started with what I'm hoping that you take away from this presentation. Consider the diversity in health literacy needs to improve impact of services and intervention. Impactful health literacy actions are rooted in local context and generated through local wisdom. I can give you some insight into what we've learned in different contexts, but we don't really know exactly what will work for you that needs to be generated in the local context. And feel free to connect to learn more about the work in this field that is ongoing. Thank you so much.
Thank you so much, Mark. I do think we have time for a couple of questions. Do any one of the participants have any questions? Please raise a hand. No one? But I have a question, Mark. You showed us that the difference between the patients and the healthcare professionals were large on the domain of critical appraising information and also having support for healthcare. Have you thought about how to deal with this kind of difference between healthcare professionals' view and the patient's experience of health literacy?
Yeah, that's a very good question. I'm just putting the slide back up to know, so everyone knows what I'm talking about. It's very challenging because I do want to emphasize that this doesn't necessarily mean that healthcare professionals overestimate patients, right? Because this is a self-reported questionnaire. So it's just a clear indicator that they're not on the same page as patients. Now, when it comes to dealing with this challenge, I think it's very important for us to educate our healthcare professionals that it's very difficult to make these estimations, particularly relevant. Okay, which profiles are we most likely to have discrepancies with our patients? And then when it comes to overcoming these barriers or overcoming these differences, I think what's important is we tend to go by our intuitive estimations when it comes to health literacy. And I think the conversational health literacy assessment tool, for example, can be a really powerful tool to really surface what the actual challenges at the point of care are. No assumptions, but having a conversation about what those challenges may be. And I recognize that that isn't always possible, that there isn't always time to do a full conversation about health literacy needs at the point of care for the individual, but I do think it's very important. And just to emphasize, someone that came back in the last conference that we had about this topic, they were saying, oh, I tried doing teach back at home, you know, the teach back method or in my practice, and people were I noticed that actually of all of the things that I say, I can only give 2 or 3 examples that really stick, or 2 or 3 messages that really stick. So the lesson there wasn't don't do teach back because then you'll know. The lesson was there was actually we may need to be much more conscious about the fact that healthcare is difficult and healthcare interactions are challenging, and we need to acknowledge that and make time for more productive conversations about what those individual needs may be.
Thank you, Mark. Very good answer. And you have received one question and answer here from Richard, and he tells you that it was a great presentation. So thank you so much.
Thank you.
Now we will go further to the next presenter, and that is. Can you see my presentation now?
No, we can't see. We
I'm
can see you,
sorry.
Christina.
Okay. And the next one is Gunhild Brøs, and she is head of department for the service nursing at the Clinic of Cardiology at St. Olav's University, and also an associate professor, Department of Public Health and Nursing in Trondheim in Norway. And Gunhild will present on the topic health literacy and risk factors for coronary artery disease. Welcome, Gunhild.
Now you can hear me. Sorry, and you can see the presentation. So thank you for the invitation to speak about health literacy and the association with risk factors for coronary artery disease. Cardiovascular disease are the leading cause of death globally, taking an estimated 18 million lives each year. This has particularly been linked to coronary artery disease, which is a disease caused by atherosclerosis that develops when plaque builds up inside the coronary arteries that reduce the blood flow to the heart muscle. The most important behavioral and clinical risk factors for coronary heart disease are unhealthy diet, physical inactivity, tobacco use, physiological diseases, as well as high blood pressure, blood glucose, blood lipids, and overweight and obese. So this is modifiable risk factors, meaning that the patients can take steps to change their risk profile. So a combination of preventive and therapeutic strategies, such as percutaneous coronary intervention, PCI, has led to a reduction in mortality in recent years. The benefits of secondary prevention by treating risk factor is well documented in the literature. So successful secondary prevention also requires patients to learn about risk factors and maintaining a healthy lifestyle. So therefore, implementation of secondary prevention intervention, including health education, is highly recommended. But despite this recommendation, risk factor control is still surprisingly low, while many patients with coronary artery disease have an unhealthy lifestyle in terms of persistent physical inactivity and smoking. So, do health literacy matters? I think so, but more research was needed to determine aspects of health literacy and e-health literacy and the association with risk factors among patients undergoing PCI. So therefore, I performed 2 studies. The first study aimed to determine health literacy, whether health literacy was associated with the established risk factors at the index admission for PCI. And the second study aimed to determine whether using the internet to find health information and e-health literacy was associated with risk factors at the index admission and 12 months follow-up in these patients who had undergone PCI. So these two studies was part of the Concord PCI project, a large multicenter prospective cohort study. All adult patients undergoing PCI at 7 large centers in Norway and Denmark were prospectively screened for eligibility from June 2017 to May 2019. And the inclusion criteria were aged about 18 years old and living at home at the time of inclusion, and the ability to speak Norwegian and Danish or to complete the questionnaires, because we were collecting a lot of data, a lot of patient report data, and elements of health literacy were measured using 4 of the 9 scales of health literacy questionnaire. The scales assess the perspective of patients' knowledge and confidence to access, understand, and appraise information, as well as social support for health. We used the e-health literacy questionnaire, e-HEALS, to measure e-health literacy. According to psychometric properties assessed within this population, we used the questionnaire as a 3-factor model with the 3 scales: awareness and knowledge of what health information is available on the internet and where to find it, skills and behavior needed to assess health information, and the 3rd scale, the ability to evaluate the health information once accessed. And we asked the patients about smoking and physical activity status, and the hospital anxiety and depression scale was used to assess symptoms of anxiety and depression. In addition, we used clinical data from medical records. So all the 3,417 patients included in the Concord PCI project were included in the analysis. And as you can see in this picture, the mean age was 66 years old and the participants were mostly male. 36% had a history of coronary artery disease and nearly half had hypercholesterolemia. 17% were smokers, 76% were non-adherent to physical activity recommendation. And more than 70% of the patients reported being overweight or obese. And the proportion of patients reported mild to severe symptoms of anxiety and depression was 24% and 14% respectively. So first, I will take you through the result from the first paper about health literacy and risk factors. The mean score for social support for health corresponds to the response option agree. For appraisal of health information, the mean score corresponds to the value midway between the response option disagree and agree, which indicate that a substantial number of patients struggle to identify good health information and reliable sources of information. And for the aspects ability to find health information and understand health information well enough to know what to do, the score was midway between the response option, sometimes difficult and usually easy, indicating that a substantial number of patients experienced difficulty in relation to these aspects of health literacy. These figures show the most essential findings from the study. The green arrow indicates that the results are statistically significant, and the direction of the arrow indicates the direction of the risk factor. For example, as you can see in this figure, there is a green arrow under the scale ability to find and understand health information pointing down, meaning that for each score higher on the health literacy scales, the body mass index decreased. I will also inform you that that this regression analysis are adjusted for age, sex, education level, and medical history. Here you can see a green arrow pointing down, meaning that those with a higher health literacy score had 24 to 72% higher likelihood of being a non-smoker. For physical activity, the green arrow are pointing up, indicating that for each 1 unit increase in score of the health literacy scales, the estimated weekly physical activity was 12 to 20 intensity adjusted minutes higher. A higher score on the social support for health, ability to find health information and understand information were significantly associated with fewer anxiety symptoms. But interestingly, a higher score on the appraisal of health information was associated with more anxiety symptoms. A higher score on the health literacy scales, except for the appraisal scale, were significantly associated with fewer depression symptoms. And finally, I will take you through the result from the second paper about e-health literacy and risk factor. The results show that most patients had access to electronic equipment with internet access. 74% of the patients reported using the internet to find health information, which decreased at 12 months follow-up. There was a statistically significant decrease in e-health literacy scales awareness and skills between the 2 time points. But the e-health literacy scale evaluate had the lowest score at the index admission and at 12 months follow-up. I think one reason for the reduction in use of internet for health information and e-health literacy from the index admission to the 12 months follow-up may be that the patients were not included in any organized e-health program during the follow-up period. And this data was also collected before the pandemic. So the likelihood of being a smoker was significantly lower among those who used the internet for health information, both at baseline and 12 months follow-up, and for those with a lower score on the e-health literacy scale skills. Those with a higher score on the e-health literacy scales awareness and evaluate at the index admission for PCI were also less likely to smoke. Those who used the internet for health information reported 10 minutes more intensity-adjusted physical activity per week compared to non-users at baseline and 13 minutes more at 12 months follow-up. And the estimated weekly physical activity level at the index admission and 12 months follow-up was 3 to 5 minutes more higher per week per 10 unit higher score on the e-health literacy scales. And those who use the internet for health information reported statistically significantly more anxiety symptoms. However, the anxiety symptoms were lower among those with higher score on awareness and skills at 12 months follow-up, and lower among those with higher score on the scale ability to evaluate health information at the index admission and 12 months follow-up. The depression symptoms were lower when the e-health literacy scales increased, except for the scale evaluate at 12 months follow-up. And the LDL cholesterol, the bad cholesterol, was lower among those who use the internet for health information and for those with higher e-health literacy. So difficulties exist with respect to all aspects of health literacy and e-health literacy. Overall, a higher health literacy and e-health literacy was associated with more favorable behavioral and psychological risk factors for coronary heart disease. Patients' health literacy and e-health literacy, as well as individual risk factor profile, should be considered and develop secondary prevention program for patients after PCI. And the healthcare system need to implement measures that respond to the patient's health literacy, e-health literacy, to improve individual risk factor control. So, health literacy matters in secondary prevention for coronary artery disease. Thank you for your attention.
Thank you so much, Gunhild. Do we have any questions from the participants? Mark, you have a question? That's good.
Yeah, if there's time. Thank you so much for this interesting presentation. I have to ask you about the most interesting finding to me is that anxiety seems to be higher among people with higher scores in critical appraisal and also internet users. Why do you think that is, and what should we do to address those anxiety symptoms? Is that something that we should address?
Yeah, I think we should address that. So your first question was the association between e-health literacy or those who use the internet for health information who appear to have higher anxiety symptoms. It may be that this group of patients are very active on social media, Google, trying to find explanation about symptoms, question. It may be because of that, because you can see as well that they have, if they have lower e-health literacy, they also have higher anxiety burden. So it may be, but I think we have to look more into that group of patients.
Thank you, Gunhild. There's one question here. Is internet treated as a utility in Norway? Do you have an answer to that, Gunhild?
Treated as a what do you mean?
Utility, nytta.
Yeah. For health, health information, yes, I think so. Many patients and relatives use the internet to find health information, and I think the healthcare system need to acknowledge that and develop information that are quality approved and help the patients find it.
It's an answer to that or a new question. So it's readily available as electricity. It's a new question from the same participant. So it's readily available as electricity. Yes, it is. In Norway, it's really available all over the part of Norway.
Yes.
At some places,
right.
at some places it might be difficult, but almost all over Norway we have the availability to have internet access.
Yeah, that's right.
Well, thank you so much, Gunhild, for a really nice presentation. I think we will go over to the next one, and that is, I'm sorry, I need to share my screen first. That is that is Signe Olsbø. She is a doctor and physician. She's a PhD student at the Oslo University Hospital Department of Pediatric Surgery in Norway. Her topic is parental health literacy in pediatric care. Sprung disease. So welcome, Signe.
Thank you very much. Can you hear me and see my slide?
Yes, we can.
Okay. Hi, everyone. So my name is Signe. I'm a surgeon in training, but I'm currently on a mission to inspire surgeons to also care about health literacy. I'm conducting research to try to figure out something about the health literacy of parents who have children with congenital malformations or conditions in the gastrointestinal system. So this presentation, I will focus on Hirschsprung's disease, which is a rare disease that I will tell you a little bit about in a minute. How these minutes will be useful, I'm going to try to increase your understanding of parental health literacy. And I'm going to try to raise awareness of the challenges faced by parents of children with specific health needs. And lastly, try to create a link between parental health literacy, healthcare professionals, and optimal healthcare. So Hirschsprung's disease, it's a very rare disease. It affects 1 in 5,000 births. So in Norway, that's only 10 to 12 per year. In the US, that would account for, I think, around 750. It's a condition in which there's a lack of nerve cells in the most distal part of the last part of the colon, so the large intestine. So these children need surgery after birth, in which the healthy part of the large intestine is pulled through to the anal opening. And there's created an anastomosis at that point. So as you can imagine, when recreating this system, there's chance of problems afterwards. And more than 50% of these children actually have serious problems with long-term fecal incontinence and or constipation, and they need long-term follow-up. So in Norway, almost everyone is diagnosed in the newborn period. They are operated within the first months of life, and they are followed at our department until they are 18 years quite regularly. And their main problems, just to give you an impression of what how we treat them, is first of all, fecal incontinence. That's a big problem, but also constipation and nutrition. And there's a very big psychosocial aspect of this patient group that needs to be considered in the clinic as well, which definitely plays a role in health literacy research. So a parent of a child with Hirschsprung disease has a lot of roles. As you can also, a lot of these roles are the same for parents with children with other chronic conditions, but specific for the Hirschsprung parent is that they need to contribute in shared decision making. So they need to know something about which choices they're making for their child. They need to understand what the doctor or the nurse is telling them, and they want to feel understood. The coordinator has to do with appointments. 30% of these children have other comorbidities as well. So often they have specialized healthcare needs within other departments, not only the pediatric surgery. And the parents need to coordinate activities with school, daycare, for example. For navigation, they need to know where they can find information, who they can contact and when. And they need to know something about which sources they can rely on. Is this information true? Is this information good? Can I use this? Does this apply to my child? Furthermore, the nurse part, they need to actively monitor bowel management, which is not always easy, and nutrition plans, which are almost always specialized per child, and also recognize signs of acute illness. These children have a risk of developing bowel inflammation or colitis, which is a life-threatening condition. And lastly, the mental support and supporting siblings and talking about these problems with the child. So these are the aspects of parental, or some of them at least, parental health literacy for Hirschsprung disease, for the Hirschsprung parent. And as many of you probably know, there's a clear link between parental health literacy and child outcomes. So this is a systematic review from Seidman et al. From last year, where they found a very clear association between the level of health literacy in the parent and how the health of the child, the level of the health of the child, and also how the parents acted within healthcare. So the knowledge gap, we know little or actually nothing about parental health literacy in Hirschsprung disease. We actually know very little about health literacy in parents of most pediatric surgical diagnoses. So we wanted to explore health literacy in these parents and figure out which parents or children factors were influencing the health literacy levels. So we did a cross-sectional study in which parents of children with Hirschsprung disease under 16 years old were invited to participate, and we asked them to fill out 4 questionnaires. The health literacy questionnaire parent version was one of them, which has been translated and validated to Norwegian. Also the EHILS, or the electronic health literacy scale, the general self-efficacy scale, and this last sentence I forgot to translate from Norwegian, but it's a study-specific questionnaire about Hirschsprung knowledge, the disease itself. So for the results, we had 132 parents fill in the forms. We were happy that 42% of them were fathers, which is quite unique in health literacy parental research. 50% had higher education, which sounds like a lot, but it's in the general population. It's in Norway, it's almost 40% as well. So it's not too crooked. 80% worked full-time and 36% had Norwegian as second language. So they were not speaking Norwegian at home. So these are the results from the study-specific questionnaire about Hirschsprung disease itself, and they scored actually really well on these questions. They knew a lot, they had a lot of factual knowledge about the disease itself. For example, that it's not a common disease and that it's always congenital and that the children can get more ill from stomach flu than other children. For the health literacy questionnaire, the domains with the highest scores were domain 9 and 6. So understand health literacy, health information well enough to know what to do, and active engagement. And for the lowest scores, which are maybe more interesting, firstly, they felt like healthcare providers don't actually understand what their child is going through. So that's domain 1. They struggle with the appraisal of health information. So how do I evaluate this information and how can I apply it to my child? And also they scored low in the social support domain, which is actually already established in Hirschsprung disease and many other diseases that has to do with fecal incontinence and rarity, that the social support is often low. So we wanted to figure out which parents are scoring high and low. So this table is a bit crazy, so hold on. On the x-axis, you see the HLQ-P domains. On the y-axis, you see the correlation coefficient. So the higher correlation coefficient, the higher the association with the demographic dots. So the color dots, they represent parental groups. So the purple dots, for example, that's high self-efficacy scores. So high self-efficacy correlates strongly with high scores in all domains significantly. And furthermore, we found that living with the child's other parents, that's the red dot, also contributed to higher scores in certain domains. Having higher education as well in all domains. Speaking only Norwegian at home contributed to significantly higher scores within understanding health information and active engagement with healthcare providers. And being older than 40 also correlated strongly in certain domains. So we were able to get a picture of which parents struggle with which domains. And I think it's also interesting to just tell you something about which factors we didn't find any correlation at all. So fathers and mothers that didn't give us any difference in HLQ-P scores. Also, none of the child factors, so the age of the child, whether the child had a comorbidity or a syndrome or complex disease, or the time since diagnosis, none of those things influenced health literacy, which I thought was interesting because at least in my head, I would think that if you have a child with multiple health concerns, with comorbidity, and you have a lot of contact with the hospital, then it's logical to me that you have higher health literacy. However, that was not the case in our patient group. And we're not supposed to group into high and low health literacy, but just to give you an impression of, just to give you a summary of the factors influencing health literacy, we found that parents that have high self-efficacy are over 40 years old or are highly educated, they tend to score higher. And parents not living with the other child of the parent, or parents with not speaking Norwegian or the official language at home, tend to have lower health literacy. So to conclude, parents of children with this rare disease, they experience a lack of understanding from healthcare providers, which is a bit surprising, I think, also considering they have very specialized care with a very specialized and multidisciplinary team. So it's an interesting finding. Second, they experience problems with interpreting health information. So what do I do with this information? How do I evaluate this? And how can I apply this to my child? And they experience limited social support. So we are suggesting to create tailored efforts for these parents, especially parents that are young, lower educated, non-cohabitating, or not speaking the official language at home. Yeah, so that was what I had for you today. So if there's any question, I'm happy to elaborate.
Thank you, Signe, for a really nice presentation. Really good work. Any questions? We have time for one question. No? Well, I might have a comment, or I'm not sure if it's a question. I've seen that in Mark's presentation and Gunnar's presentation, and also in your presentation, the domain of appraisal of information, critical appraisal of information, and also having support of healthcare are low in all the presentations, and I think that's quite interesting.
Yes, I agree. And I think it's a very different patient group that I am working with than, for example, rheumatoid diseases. But I guess it implies that chronic conditions in general might share the same
Yeah.
health literacy needs.
Yeah,
and
I
that they are
agree.
all specific for every patient. Yeah,
I agree with you. Thank you so much. Now we will go on for the next presentation, and that's Dulce. She is a nurse coordinator of the Department of Studies, Projects and Clinical Trials, and project manager of the Portuguese Diabetes Association. And her presentation has the topic Health Literacy and Diabetes, a Promising Relationship. So welcome, Dulce. You might need to stop your presentation, Signe. Yes, thank you.
In Portugal is good afternoon. For the other, it's good morning. I'm very pleased to be here. I would like to thank you the invitation to be in this conference. I'm very glad to be here and speak about health literacy and diabetes. It was I will present a small part of the research of my PhD in a different way. I hope you enjoy it the way that for these 10 minutes about more or less. So, as we know, diabetes is a very demanding disease because people with diabetes need to learn how to self-manage the different behaviors and treatments that they need to do to have a good diabetes control. So with this and what we know about health literacy, we would think that it's basic, and the health literacy is very important for diabetes control. But in the research, the relationship between health literacy and diabetes control is not yet clear. Some studies, some research don't found any relation, and others have inconsistent evidence regarding to the association between
we
health
cannot see the
literacy
presentation.
and diabetes control. So in this study, because we think health literacy is very important, and perhaps the instruments that we used to measure health literacy can make different, can contribute for different results. So in this study, this part of the study, we want to understand the relationship between health literacy and diabetes. And for that, we use the health literacy questionnaire that Richard already presented, and my other fellows that used this health literacy scale. So this scale have 9 dimensions, and they are conceptually distinct, and the measures are independent of their dimensions. In Portugal, this scale is already used in several countries, and in Portugal we did the cultural adaptation and validity testing. And we did the study in my place of work, the Portuguese Diabetes Association, and we include 700 people with diabetes. And it was a remote electronic questionnaire. And I think that was a limitation because we have in here 84% of people with more than 9 years of education level, and in Portugal, it's not representative of our population. For this part of the study, we did the multiple regression. And because the multiple regression have sometimes difficulty to present the results, and because it's a small presentation, I will present these results with separate in some topics to make easier to understand the results that we obtain with the regression, multiple regression. So in all dimensions, except 5 dimension, domain 5, higher levels of health literacy were significantly associated with lower levels of HbA1c. And in all domains defined, these results remain significant in all the models adjusted for the socio-demographic and clinical variables. So in this different way of present, I hope it's easier to understand and to see the results in a different way. When we think in healthcare, we can think in the dimension 1 and 6 of the questionnaire, when we have feeling understood and supported by healthcare providers, and when we think about ability to actively engage with healthcare providers. These dimensions were associated with diabetes control, and also the dimension 3, actively manage my health. So, as we already learned and listened before, the quality of communication between health professionals and persons with diabetes, family, and the other disease, of course, but in this case, we are studying. I have the pictures, is recognized as fundamental for the relationship between people with diabetes and family, because they need to participate in health, make decision-making, and have better control. When we think in health information, we can evaluate the health information using the dimension 2, having sufficient information to manage my health, understand health information well enough to know what to do, and have the ability to find good information. The dimension 5, as I already told, it wasn't associated with lower levels of HbA1c. But the other ones were associated, and as we know, relevant and relative information can play an important role of people's lives, because they can understand, they have the sufficient information to understand what they need to do, and the ability to find good information is associated with diabetes control. And it's so important when they need to manage their disease. When we think about social support, it was also associated with diabetes control, and we have in several studies that social support contributes to successful disease management. And of course, when we think in diabetes and comorbidities, the navigation in healthcare systems, when the people have higher levels or the ability to navigate in the healthcare system, they have a better diabetes control. So it's so important, and we already spoke in the other presentations, the importance of the ability of healthcare providers to promote health literacy in patients, to have the ability and responsiveness to do it. It's a very important way to promote health literacy, but it's not enough. We need to think that we live in society, and the responsibility is from everyone. We all need to identify good information. We all need to make our paper, our importance. We need to ensure that health information is accessible, clear, and have quality. I have a black in my brain. So all the information need to be clear. Patients needs to understand the information and make light in their brains, in their lives, to have a good life, quality of life, quality of their health, and to have a good diabetes control. And we need to think about all these kinds of results, because we are not in the same journey. We don't have equal rights in this journey. We don't have the same ability to understand information, to navigate in healthcare system, and we need to leave no one behind, because it's so important that people with more difficulties have the access of all the rights and all the information and all the promote of health literacy that they need. Thank you so much for your attention. And yes, health literacy and diabetes is a promising relationship.
Thank you so much, Dulce. Do we have any questions?
I can hear you.
You can't hear me?
Oh, now I can't.
Yeah. Thank you so much, Dulce. Do we have any questions from the participants? Well, I'm not sure. Well, Richard Osborne has a question. Would it be possible to study the difference pattern of health literacy to determine at what point or combine a point of levels of health literacy across health literacy questionnaire dimensions would lead to successful diabetes control?
I didn't understood the questions.
Well, the question is, would it be possible to study the different patterns of health literacy to determine at what point would lead to successful diabetes control?
It is possible. Can you repeat, please?
Would it be possible to study the difference pattern of health literacy to determine at what point would lead to successful diabetes control?
Yes, I think so. How to determine the combination, the levels of the measure would lead to. I think the questions, if I'm right, Richard, if I understood, your question is it possible to understand the different levels of different dimensions and the impact of these dimensions of diabetes control? Is that? Do you think there is a part there? Do you think it's a pattern? Perhaps it's my knowledge pattern.
I guess the question seems to be, Dulce, is
Padrão.
the combination of different domains, right? At what combination of
Yes,
scores across the domains
yes.
do we need for diabetes control?
For instance, cluster analysis.
You have the right, you have. The question is if you, the practice, if I think it's a pattern, a pattern.
Yes, and what pattern we need for diabetes control?
To some of the
Related
dimensions.
with the information or the different dimensions.
Well, Dulce, do you think that some of the domains are low in a pattern and some of the domains are high in a pattern?
Some of some people, this study, the multiple regression only give us the association between the model and the different variables. Don't give us the pattern of this of each dimension. But when I analyze the different different dimensions, we have people with different levels of health literacy dimensions. I don't know if is that what you want me to answer. Of course, when we do the cluster analysis, we can understand more what the different groups that we have in this group and the different levels of health literacy and their needs. It's that. I don't know if I answer.
I think that is your answer, Dulce. I think that's right. That it will be possible to do, for instance,
it's
analysis.
possible. Yes, the test, the statistic that we used in this part of the study only give us the association because it's multiple regression. But when we do different analysis, yes, we can have a pattern of these different levels and understand how patients, how people with diabetes have their different levels in different dimensions.
Thank you so much, Dulce. I also have a question. You told us that domain 5, the critical appraisal of information,
Appraisals, yes.
did not have any significant
No.
association with
No.
the diabetes control or the blood sugar. Why do you think it's?
We even with the person test, simple correlation, it wasn't don't have any kind of correlation. Perhaps it's the in Portugal appraisal. It's more difficult for the people. They can understand. Perhaps it's the first pass is to first step is to understand where they can find the information, to understand the information. But appraisal needs more knowledge and it's more difficult. It's advanced health literacy perhaps, and perhaps people, we don't understood why that's happened. We can have lots of thoughts, but in the way that the questions are made, the patients have more difficult to analyze and to know where to find the information. So I think it's because it's more difficult to do it. And perhaps they don't have these correlations.
Thank you. There is one more question. I think this must be the last one. How do you assess this? Is it lack of health literacy in diabetes to more to the circumstances or to the individual competence?
It's a lack of the access. It's a lack of health literacy in diabetes, do more to the circumstances or individual. I access, so health literacy was measured by the questionnaire, health literacy questionnaires, and then we did this multiple regression. I think this lack of health literacy in diabetes have different causes. It's a very difficult disease. They need to have a lot of knowledge, but it's not enough. They need to have the ability to use this knowledge and to decide what is best for their health and for the diabetes control. I think we need to see with this as health literacy is, it's a multidimensional way to see, because for one hand, the relationship they have with the healthcare providers, it's very important because the first way, some studies, some research says that patients, the first information about health is the healthcare providers that they give to the patients. So the kind of relationship that we establish with patients is very important. We need to see them as partners and not like patients that don't have the right, the ability to decide anything. So the kind of relationship that healthcare providers and patients with diabetes establish in the consultations, it's very important, but it's not enough. The way that we talk, as Mark said, the simple language, the guarantee that the patients really understand what we say, it's very important. And also the society need to have more knowledge about diabetes. So I think it's more structural than only individual competence. Of course, people with diabetes need to have competence and needs to have the ability to do the self-management of diabetes control, but we need to have this aboard, this kind of importance to give them the ability to have the ability to self-manage their diabetes, but all the society and the family also need to have competence and knowledge. Of course, that I really, really, really believe that we need to promote responsiveness in the people, in the healthcare providers. I work a lot in communication, and I think that I every day need to learn more.
Thank you so much, Dolce. Thank you. It's a really good answer. So thank you for a really nice presentation. Now we have about 12 minutes left. So I will go on for the last presentation. And that's my presentation. It's about health literacy informed intervention that reduces hospitalization and health economic cost while improving health literacy, self-management, and quality of life in chronic obstructive pulmonary disease. So first, a little bit about COPD. It's characterized of chronic obstruction. You could either have chronic bronchitis or emphysema, and it's called COPD. The main COPD symptoms is breathlessness in activity. Breathlessness in activity or at rest. They can have cough and sputum, and they can have sound of wheezing. It's a complex disease with complex treatment and follow-up. They may have several inhalation medication and several medication in total. It may be difficult to use, and some may need to use help equipment such as a chamber with their inhalation medication. Some need to use a nebulizer, and some get advices to stop smoking. Some need to go to a self-management course to learn about their disease. Some also get an action plan with their medications. They get advice about nutrition. They get advices about physical activities. Some need to use oxygen treatment also during activities. Some also need to use sleep apnea equipment, and it's also they may need to travel back and forth to different kind of healthcare service. It costs money to have a complex disease such as COPD. Some also have heart diseases, and they have several hospitalizations. So inspired by the Ophelia processes that Richard Osborne has told about in the start of this seminar today, we started this project to co-develop and evaluate a health literacy intervention that includes patients, hospital, municipalities, and university in the context of chronic pulmonary disease. In phase 1, we identified health literacy strengths and limitation in a cross-sectional study in COPD patients, and we also performed 7 focus group interviews in healthcare professionals and patients with COPD. We used this information in a co-design phase to develop a health literacy intervention with 5 workshops, and the intervention that we decided on in phase 2, we tested out in a randomized controlled trial in phase 3. So first, a little bit about phase 1. That was a quantitative study. The main result there showed us that they scored lower on all the domains of the health literacy questionnaire than in other populations. Lower psychological well-being, education level were also associated with lower levels of health literacy. We also found that about 50% have access to or uses the internet computer at home or at work. And this is really interesting when we think about all the information that we give through internet and computers today. The quality study, the focus group interviews showed us that both healthcare professionals and patients with COPD showed that they had a combating burden of insufficient knowledge on COPD and lack of information flow. They felt that they needed supporting and motivation for endurance and self-management. They felt also that they needed a strengthening in dignity and a strengthening in the feeling of security. So we used this information in the co-design phase, and we decided on a new intervention. And this was a tailored health literacy follow-up after hospitalization, where patients with COPD and nurses with knowledge in COPD and in motivating interviewed followed up patients with COPD individual with in a 8-week home visits and 4 months of telephone contact. The intervention was tailored to health literacy needs, and it was a cooperation with the multidisciplinary healthcare professionals in the municipality and the specialist healthcare service. The aim was to investigate the effect on health literacy informed intervention after hospitalization with the use of motivating interview and tailored follow-ups on hospital admission, health literacy, self-management, quality of life, and healthcare cost. And we compared with usual care. So the main results showed us that the intervention group increased in health literacy in the domains of the health literacy questionnaire, ability to engage with healthcare professionals, navigating in the healthcare system, ability to find good health information. We also found that they had lower CPD-related challenges, that is disease-specific quality of life, and they also had higher self-management. They also had 2.8 lower rate of hospitalization than the control group and about 50% lower hospitalization days than the control group. And all of this led to lower healthcare cost. So we have learned something in this project, that without the Ophelia framework, it would be no project. This framework requires a collaboration between different actors and communication across health services and health professions. What health literacy represent in practical settings seems to be very recognizable to all actors. The project manages to include the project managed to include the sickest patients, even if it's demanding, and all the partners also felt ownership in the cooperating process. They gave, for instance, economic financing, and new ideas and new projects has been developed after this project. We are now currently doing the same Ophelia process in cancers, patients with cancers, and also in caregivers of chronic diseases. The project has now been implementing and is running as a normal drift in the specialist healthcare service in cooperation with the municipality healthcare service. So this was the project about CPD patients. So do you have any questions? It's 2 minutes left of this panel. No questions? Well, that's good. Well, one, were there any difficulties you experienced in the Ophelia framework? Yes, that's a good question. It's always difficulties in every project, and the Ophelia framework, I think the main difficulties was when we applied for funding, because we couldn't, we had to give some ideas of what we thought the intervention should be when we applied, because the funding institutions do not find the gap in the literature by only saying that we need to do health literacy studies. And when we come to the phase 3, where we are testing out the intervention, we need to know what kind of intervention we actually are going to do. So that was difficulties. And also we used a lot of time doing phase 1 and phase 2 and phase 3. And the our cooperation, our cooperators got a little bit impatient during the process, and they wanted to find the solutions a bit faster than we could manage. But all over, we thought that the Ophelia process was a success factor to do this project. We managed that the participants and the our cooperators got ownership, and that was a really good thing in able to do the whole project. There's one more question. No, there was not more. I'm sorry. Well, I think the time is now finished. I have to thank you all of the presenters for all of the nice presentations you have had and all the nice questions from the participants. So thank you all for this nice panel. Have a good day.
Thank you, Christine. Thank you so much.